Doctor, thanks for joining us here on Health Connection. Can't sleep. What you don't know can hurt you. We're going to talk about insomnia. So let's get a clinical definition first and foremost. What is chronic insomnia?
Well, the word insomnia in its simplest form means a difficulty initiating or maintaining sleep. And we also kind of lump into that term the word perception. So a lot of patients with insomnia, they sleep just fine when you put them in the laboratory, but their perception of sleep is quite poor. So we're willing to call it insomnia if you call it insomnia. All of us have acute episodes where for a day or two or a week or two, usually secondary to some emotional trauma, where we can't sleep. We call it chronic insomnia when we're talking about difficulty with the perception or reality of sleep that lasts longer than 3 weeks or is recurrent for a longer period than that.
What's the impact of not treating chronic insomnia?
Well, one, it's emotionally very frustrating. And two, the difficulty or perception of difficulty with sleep is often underscored by the same perception of fatigue and anxiety and restlessness during the waking hours. So what happens to you at night ends up affecting you during the daytime as well.
Well, given its seriousness, why is it so often left undiagnosed and untreated?
Well, it's not necessarily undiagnosed. It happens to be, in fact, the single most common sleep complaint when you actually ask the question. The problem is that it's so common a complaint and the causes are so many and so varied that it becomes a problem when you go in the doctor's office that the doctor really just doesn't want to hear it. It's difficult to treat. The doctor will often throw a sleeping pill at it just to make the complaint go away. And the end result is that patients remain unhappy, and so it becomes a subject that is just not brought to the surface very often.
Well, let's take that under treatment or non-treatment. What is the impact on a person's health if it's not properly treated?
Well, when there's a chronic sense of frustration and a person who can't sleep at night after a period of time has a self-fulfilling prophecy where they get more and more frustrated and they anticipate going to bed as being problematic. So they know they're going to have a rotten night's sleep, and guess what? It really does happen. They sit there and they tell themselves, I know I'm not going to sleep, I know I'm not going to sleep, and sleep never seems to happen. Or if they fall asleep, they wake up a little while later and have the same frustration repetitively through the night. The end result is that during the daytime, there's a level of anxiety and nervousness and sometimes even depression that can arise.
The impact of chronic insomnia in the bigger picture, work, healthcare costs, workplace safety, driving safety, give that some color.
Well, the tendency is for people to demand drugs or to treat themselves when they have perceptions of chronic sleep difficulties. So there's a lot of Sominex and Benadryl and other over-the-counter preparations that are sold. A lot of those preparations can actually lead to being hungover and drowsy during the daytime hours. Being sleepy is a recipe for accidents. These are individuals that really demand of their doctor, and most doctors acquiesce by writing prescription sleeping pills. And again, these drugs can be, in a technical sense, maybe not, but in a reality sense, they're habit-forming or addicting. And particularly in the elderly, they can lead to things like confusion, memory loss, symptoms very similar to Alzheimer's or dementia. And falls are more common in people who use sleeping pills. Accidents are more common in people who use sleeping pills. Lastly, in a younger population, the more popular sleep aid is alcohol. And yes, aunts and grandmas and grandpas sometimes have a nip in the evening time, but in younger individuals with chronic insomnia, they'll often way overindulge in alcohol, trying to get themselves to be able to go to sleep. And alcohol is a horrible sleeping medication. It actually allows you to fall asleep, but then you spring right back up later in the night wide awake.
You answered this question earlier, but let's flesh it out a little bit. Is chronic insomnia difficult to treat?
It's frustrating to treat. It's time-consuming to treat. It requires a physician that's sensitive to all of the emotional overlying themes that a patient will bring into the doctor's office. So the doctor has to sometimes inquire about family struggles, financial, emotional, marital difficulties, all of those elements of life that make up who we are and the frustrations and the problems that we have. Because the problems that we have during the daytime often end up creating difficulty at night. So it requires a sensitive physician to explore those themes and to properly address them, instead of a physician just simply throwing a sleeping pill at the patient, hoping to make the complaint go away. It also requires an aggressive intervention strategy. So there are medical excuses, chronic pain, thyroid deficiencies, difficulties breathing, difficulties with arthritis that can also impact a person's sleep at night. And so it does require a rather exhaustive strategy on the part of a caregiver to find out all of the things that are wrong with a person's health, both physical and emotional, that could be playing a part. And then it requires a very systematic strategy to address those issues. Lastly, it's important to understand that insomnia can often respond to a time-consuming approach to alter behavioral issues, particularly in the elderly when they sleep poorly. A good example is that one of the things they do to themselves is they go to bed earlier and earlier and earlier. And before you know it, you have somebody who's 70 years of age going to bed at 7 o'clock at night and wondering why on earth they can't stay awake past 3 o'clock in the morning. They only needed so much sleep. The sleep they got was frustrating, broken up, and they did the wrong thing to try to address the problem. So it requires a caregiver who's willing to address all of these strategies and problems, including misbehaviors, in order to successfully treat insomnia.
You mentioned earlier throwing a pill at it. So let's throw a pill at it because we have to. Which prescription drugs work best in treating insomnia?
Well, historically, the drugs that are relatives to Valium were and probably still remain one of the major players in terms of pharmacologic therapies. We have a number of different Valium derivatives that are still used. There are a lot of newer medications that have come out within the last decade. They're not quite so habit-forming as Valium-type drugs, but they still have consequences in terms of memory dysfunction, imbalance, falling, breaking bones, particularly in the elderly.
A sleep aid that you hear a lot about, Ambien.
Ambien's a great drug, but it's not for everybody. There are some people that you take an Ambien and the next day they have a rebound anxiety sort of phenomenon. And the next evening, it can actually be even more difficult to get to sleep as it was compared to the very first night they took the drug. So there's a tendency for Ambien and in many of these other sleeping pills to kind of have a very quick behavior of needing them every night. As a drug to help with occasional or intermittent or very short-term insomnia, it's a good drug. But particularly in the elderly, it can be very, very difficult and hazardous The elderly need to be very cautious about using sleeping pills. It's not to say I don't prescribe them, I do, but it has to be within a strategy of knowing what you're doing and being very cautious, and the patient understanding the consequences and potential problems.
Continuing on the subject of drugs, long-term use of these drugs, your concerns?
Well, in a younger population, you become concerned about a sense of habituation or habit forming. It's not addicting such as narcotics or pain medications are, but you do tend to become dependent on using these medications. In the elderly, the hazards are memory dysfunction, balance, breaking bones because of falls. It is often difficult when examining an elderly patient with a complaint of, for example, memory problems, to know whether it's something related to the nervous system or, in fact, the medications they're taking.
Let's go over the counter here for a minute and discuss that. Sleep aids like antihistamines, Sominex, pain relievers like Tylenol and ibuprofen, melatonin, chamomile tea, things like that. What are your thoughts?
I think as fairly mild sleeping pills, they can be very helpful. I don't think that they help when taken every night, night after night. I think their benefit tends to wear out its welcome. That said, I have patients who have been taking Tylenol PM for years and swear by it, saying that it still works for them, 2 years after they started taking it every night. The good news is that those medications are pretty safe.
How much of that could be placebo effect?
Probably a lot of it. But at least for the most part, if not taken excessively, a handful of pills at a time, the medications are pretty safe when used like that.
If you're having trouble getting to sleep, if you feel like you have a chronic insomnia problem, when is it time to call the doctor and seek professional help?
Well, I don't think you need to pick up the doctor at 3 weeks and 1 day after you've been having difficulty sleeping. But I do think that if the person has a perception of rotten sleep that's been going on for months, I think it's very reasonable to make sure they bring that up with their physician, or maybe even make an appointment to discuss that in particular. One of the problems with sleep and when you go to your doctor is it tends to become buried among all of the other health complaints. And that's why the doctor doesn't often spend a lot of time on that subject and probably too liberally just writes a pill. But if you have an appointment whose sole purpose is to address the issue of sleep, maybe that would give that a better opportunity to fully explore the problem.
At what point does it become appropriate to seek the intervention of a sleep specialist?
Well, I'd say about a day after it started, but that would be a little bit excessive. In general, if the strategies that you've employed yourself, the strategies that your primary care physician have tried, have not properly satisfied the person's perception of good quality sleep or how they feel during the daytime, be that 1 month, 2 months, 3 months into it or longer, I think it's very reasonable to seek the assistance of a specialist in sleep at that point.
Doctor, thank you very much for your time.
You're welcome. You're welcome.